Hello, everyone. One of you guys asked me to look into this Fenofibrate as a treatment for COVID-19. So I had a little bit of time and I decided to look into it. So Fenofibrate is an anti-lipid and anti-cholesterol drug. It's tr used to treat high cholesterol and high lipids. It's not prescribed too much in the United States because most people in the United States are on statins for this. So like Lipitor, Zocor, those kinds of drugs. So this is a drug that I haven't seen very many people on. In fact, I've never seen anyone on it in the United States. Now, I'm not an internist, so I don't really treat hypercholesterolemia. So it may be used in other places, but I just don't see very many patients in my surgical patients that come through and I review their drugs before doing surgery. But anyway, it's a very cheap old drug made in the 1960s, um, relatively safe. It's got the normal side effects like constipation, diarrhea, heartburn, headache, that kind of stuff. Can lead to some other more serious side effects. This is fairly typical for most of the drugs that people are on. Like statins would have a similar profile. Anyway, I went back and I looked and I found the two papers that are dealing with this and COVID-19 that are of interest. The first one is this one, which I'll link all these papers below in the description. This one's out of the UK, and basically, let's go through it. This part in the introduction says, okay, yeah, COVID is bad. And then they say, while vaccination has been shown to reduce infection rates and severe disease, we don't know how strong and how durable these effects are. And as we know, vaccination efficacy has gone in preventing infection has gone down. Vaccine efficacy in preventing severe disease is still pretty good, but our immune response slowly degrades after vaccination. So therapies are needed, and so people have been looking into therapies, and then they're saying, because it's with the rapid escalation, it doesn't leave enough time for us to look for new drugs. So what people are doing is looking for old drugs that could be used possibly, and there have been several trials, the principal trial, the together trial, which we talked about, the recovery trial, the solidarity trial. There's all these huge trials looking at old drugs, and they've tested, hydroxychloroquine, which didn't pan out, ivermectin, which, is still kind of up in the air, whether it works or not in these trials. Um, Lots of small trials say that ivermectin works. The single large trial we have says maybe it doesn't work, but the dosing was maybe not the greatest in that trial. Anyways, they've looked at metformin, ivermectin, hydroxychloroquine, dexamethasone. Dexamethasone is found to work. Anyways, they're saying we're going to look at other drugs, and what these people are doing is they are looking at they what they tried to do is they found out that the ACE2, which is how the spike protein gets into the cell, is a dimer, and if it dimerizes, so if two of them get together, it may reduce the number of receptors. And the other thing they noticed is that this fenofibrate decreases the stability of the receptor binding domain of the spike protein. And so what they did is they made this kind of cool assay. And let me scroll down to the picture. Okay, here we go. So they made this cool assay where here's the um, ACE2, and this is on the cell surface. They link this to two molecules that when they come together, it produces light. So basically, when it produces light in their assay, you know the thing has dimerized. What they did is then they made this construct in a bunch of cells, and they plated the cells, and in each of the wells they put a different drug, and they found out that fenofibrate causes increased dimerization. They also found out it destabilizes the receptor binding domain, and so after that they did a study where they had cells that could be infected by a SARS-CoV-2 virus, and they treated those cells with fenofibrate, and basically they found out that it decreases the amount of infection by between 18 and 65%. So that's good news. Um, so the one thing to know is you cannot read into these in vitro studies. In vitro means in the lab too much because a lot of things work in cell culture. Like there have been so many things that have cured cancer in the lab, but when you take it into people, it just doesn't pan out. So just because it works in a lab doesn't mean that it works in people. Just because it decreased infection in the lab and they have a presumed mechanism does not mean that it's going to actually help when you give it to patients. So they understand that, and they say, you know, you do need to test it in people. And in fact, someone has tested it in people, at least a little bit. This is the other paper. This one is out of Israel, and this is obviously a metabolics lab because they have a totally different mechanism. So the first paper thinks that the mechanism is by causing dimerization of the ACE2 and by destabilizing the receptor binding to the ACE2. They think that's how this fenofibrate is working. This guy works in a metabolics lab, so he's interested in metabolism of the cells, and he believes that COVID-19, the virus causes metabolic derangements in the cells, and it causes lipid accumulation and changes in lipid metabolism, and that's why he's using a lipid drug, fenofibrate. So what he did is he showed that the fenofibrate reversed lipid accumulation and blocked replication in cell culture. So sit in the lab. Then what he did is he looked at a bunch of Israeli patients that got COVID and kind of did a post hoc analysis, so kind of retrospective study looking at people that had fenofibrate who had been taking it because of lipid problems. And the ones that were taking fenofibrate seemed to do better than the people who weren't taking fenofibrate. He did another analysis looking at large numbers of patients from Europe and the United States and kind of found the similar correlation. So this is a correlation. It just says that people who are taking fenofibrate seem to do a little bit better, which doesn't mean that fenofibrate has anything to do with it. Remember, correlation does not mean causation, but it opens that hypothesis, and then you need to test that hypothesis. So he kind of tested it. He treated 15 patients with this fenofibrate, um, and they all got better. Now, that is just an observational study, really, because there's no placebo wing. They did not have strict inclusion criteria or anything, so it's not a trial. It's basically something where like they gave the drug and they just saw what happened, and people seem to do well. We don't know would they have done well whether or not you gave them the drug. Maybe they would have done fine without it. It just you can't tell. Um, this information is promising, but you can't really bank too much on it. It's far too early. And this, these people understand that too. They said our work charts the metabolic response of human lung epithelium to SARS-CoV-2 infection, demonstrating that virus-induced lipotoxicity is a driver of immunoinflammatory stress. Our data suggests that upregulation of lipid oxidation might be an effective therapeutic target. These findings are supported by our non-randomized clinical study. So that's their, where they gave it to 15 patients and they noticed that they got better. But again, they might have gotten better even if you didn't give it to them. The definitive answer regarding the efficacy of fenofibrate for the treatment of COVID-19 will require the execution of large randomized controlled clinical trials with meaningful clinical outcomes. So that's right. You can't say that this thing works. There's a presumed mechanism. It seems to help in cell culture, and it seemed to help when you give it to people. That does not mean that it works. That just means that maybe it works. And the only way to figure out if it works is to run large randomized controlled trials in these things. And so two randomized placebo-controlled trials are ongoing. And then I looked up these two, and here they are. This one is planning on enrolling 50 patients. So that is a small trial. That's a very small trial. Now, there's two kinds of trials. One is like an early intervention trial, which means that you're going to give it to people as soon as they get it um, to see if it helps them recover. And in those trials, you need lots of huge numbers. You should have at least 1,000 because most people are going to do well. And most people who get COVID-19 are going to do fine, no matter what you give them. You could give them Twinkies and they would probably do well. So if you just had 50 patients that got COVID-19 and you gave them something and they all got better, you don't know if what you gave them made them get better. they would have probably gotten better statistically on their own. Now, if you have like 1,000, then a certain percentage of them are going to do poorly because you have big enough numbers. And then you can tell if your intervention is helping them. However, these, if you look at the way that they're running their trial, you have to look at what's called inclusion criteria. So what they're doing is they are looking at um, patients that are positive for SARS-CoV-2, obviously, adults, so greater than 18 years of age. And then, see, this is what they mean. They are looking for people that are admitted to the hospital. So these are people that are already sick enough to go to the hospital. So that's those people are more likely to do bad because they're already kind of doing bad. So if you run a trial like that, you can use smaller numbers. All right. Then this trial is looking at 700 participants, and they're doing an early intervention trial. So they're doing just anyone who gets it. So I don't know if 700 is a large enough number, but that's a pretty good number, close to 1,000. So if you have 700 participants, you would expect a few of them to do poorly from the infection. Um, so again, if you want to do an early intervention trial, you need to have large numbers. If you are going to do a trial on people that are more likely to be sick, like if you were to um, just say like I'm only going to treat people that are over 70 because we know they do poorly, then you can use much smaller numbers. But anyway, it's very interesting. There is a presumed mechanism. One guy thinks it's because of the UK group thinks it's because of destabilization of the receptor binding domain and the ACE2 dimerization, and the Israeli group thinks that it's because of the metabolic derangements in lipid metabolism within the cell that the virus causes. Whatever the mechanism is kind of only of academic interest. At this point, most people, what they care about is the safety profile acceptable? Is it relatively safe? If you give it to early intervention people, it better be very, very safe. If you give it to a more advanced disease, then you can tolerate a greater safety risk, more side effects, because these people are likely to do more poorly. So you can accept higher side effects. Just like for cancer treatment, chemotherapy drugs have extremely high side effects, but we accept that because cancer is so dangerous. Um, Early stage COVID is not very dangerous at all, so you need a very safe drug. And moderate to severe COVID then has much higher danger, so you would accept much higher risks in the intervention. Anyways, what we want to know um, is it safe? Is the safety profile acceptable? And does it work? The mechanism by which it works is kind of only of interest to scientists, not really of interest to patients or the treating doctors. Okay, so I would say it's very early to be too excited about fenofibrate, but it, could be potentially promising. We should await the results of these clinical trials that are ongoing. There's two of them currently. If they show any results, we will definitely be hearing about it, and I'll probably explain those trials once they come to light. Thanks for watching.